So welcome everyone to this part of the second phase of the 6th Global Symposium on Health Systems Research. I trust that you've also been following the other sessions and making the best of the virtual format and the ability to participate from your own offices or drawing rooms or wherever you are, rather than having to travel thousands of miles. My name is Kabir Sheikh and I'm the policy advisor at the Alliance for Health Policy and Systems Research, which is a partnership hosted by WHO. And I'll be co-chairing today's satellite session with my colleague Jocelyn Clark, whom you can also see. We'll divide the session into two parts, a panel with presentations followed by a short audience Q&A. And then the part that Jocelyn will be chairing is a forum during which the participants will be encouraged to engage in an open discussion on different themes that have arisen as part of the panel. And there'll be further questions and engagement from the audience. Can I have the next slide, please? So the first part of the satellite session, which I'll be chairing now, is a panel on what is being done to strengthen institutional capacity for research on migration and health. And we have a wonderful lineup of panelists whom I'll introduce shortly. Each of the panelists will speak from their own experiences of strengthening institutional capacity for research on migration and health. Later in the session, I'll hand over to Jocelyn, and Jocelyn, as you may know, is executive editor with the Lancet. And Jocelyn will be chairing the forum, which will be focused on moving towards an agenda for research capacity building on migration and health. The session is jointly organized by Lancet Migration, together with the WHO-hosted special program for human reproduction, HRP, and the special program on infectious diseases of poverty, TDR, and the Alliance for Health Policy and Systems Research, which I'm a part of. We also acknowledge at this point the UK Foreign Commonwealth and Development Office, erstwhile DFID, for their joint support to the Alliance, TDR, and HRP, which has enabled us to organize this satellite session. So the focus of this panel session is going to be to explore strengthening institutional capacity for research on migration and health globally. And as we know, research on migration and health is a relatively new area, which needs to draw on many different disciplines and requires a strong understanding of how to translate evidence into policy and practice. So why is it important to talk about strengthening research through a lens of institutional capacity? This presentation follows up, this panel follows up on several global, regional, and country processes and discussions around migration and health that many of the participants and many others have been involved in over the last few years. We recognize that many useful conversations are taking place, but also that is very important for such conversations about research agendas, responding to the issues, and doing research on migration and health and on migrants' health need to be broadened and to be happening closer to the real issues confronting health systems as they grapple with issues around health and migration on a day-to-day basis. And this requires strong research capacity, not only for generating, but also for using research, especially in low and middle income countries, where the concerns around migration and health, as well as the need for evidence-informed policy and action on the subject is greatest. This is the work of research capacity building that many of us have historically been focusing on. And that is the focus of the joint FCDO-supported program of work by HRP, TDR, and us at the Alliance, all entities hosted by WHO. And we've been working together with PAHO and other colleagues in that region, including Professor Julian Fernandez, who is also going to be part of this panel. My colleague Anna Thorson from HRP will describe that program in greater detail during her talk. Professor Jo Veary will discuss her extensive work on creating international partnerships and migration research from her base in South Africa. Professors Fuad and Fernandez will outline their experience of building institutional capacity in Lebanon and Colombia, respectively. And my colleague Gary Aslanian from TDR will discuss the experience of implementation research on migration with a focus on infectious diseases of poverty. But first, we have Miriam Orcutt of Lancet Migration. We'll talk about the extensive work that Lancet Migration has done in the wake of the publication of the Lancet Commission on Migration and Health. of which at least 4 of us, I think, are commissioners, and many others were involved in different capacities. Miriam has also been one of the driving forces behind organizing this session, and my sincere thanks to her for that. So it promises to be a very exciting session, and I'm certainly excited by the prospect of listening to the speakers. Can I have the next slide, please? But before we can move on to the speakers, just a few tips on using the platform. There's a Q&A session. There's a Q&A button on your interface, which you will see on the right-hand side. So please feel free to input questions at any point in time. You don't have to wait for the Q&A session. If you see something that speaks to your interest and you want to pose a question, please do so. We will be reading those questions during the Q&A and responding to them. There's also a support chat tab if you need to click on that. And do note that the sessions are being recorded. And a note that while we have 2 hours for the session, which is quite generous, we recognize that people may get tired by the end of 2 hours, so we may not take the full 2 hours, and we'll aim to finish a little bit before, but we'll keep a little bit of buffer, maybe 20 minutes ahead of time, and we may use the last 20 minutes if we have to, but we'll aim not to. Next slide, please. It's my pleasure to introduce our first panelist, Dr. Miriam Orcutt. She is Executive Director, Lancet Migration, a global collaboration to advance migration health. She is a Senior Research Fellow in Global Public Health and Forced Migration at the Institute for Global Health at the University College London. She's a trained medical doctor with a decade of experience in global public health. Academic and policy work focuses on forced migration and the health system's response. So over to you, Miriam, for your perspective from Lancet Migration, regional research capacity strengthening through formation of Lancet Migration regional hubs.
Thank you so much, Kabir. It's a huge pleasure to be here to form part of this panel discussion today and to represent Lancet Migration. So in my presentation, I will focus on the perspective of Lancet Migration, particularly on regional research capacity strengthening and outlining some of what we've learned to date through the formation of the Lancet Migration regional hubs. So first of all, for those of you who may not know about us, what is Lancet Migration? So this is a global collaboration between the Lancet and researchers, implementers, and others in the field of migration health. And we aim to address evident gaps and drive policy change. Our work very much builds on the recommendations of the UCL Lancet Commission on Migration and Health, which was published in December 2018, and was the result of 2 years of work of 46 authors from over 20 global institutes, and many of them are panelists here today. The main messages from the Commission still ring very true today, particularly on how to include migrants in universal healthcare, inclusion of migrants in existing health systems, and ensuring access to healthcare for all. Some of the main research recommendations from the Commission focused on the need to improve high quality data collection for migration and health, for example, through adding migration-related questions to regularly administered surveys. Secondly, to improve engagement with migrant populations using more participatory approaches, and to ensure that the research responds to population needs and that migrants and local communities are included in research prioritization, policymaking, and the decision processes. And finally, to support capacity development among migration and health researchers and institutions in the global south through specific funding initiatives and supporting research networks. And I'm going to focus primarily on that recommendation, the third one in this presentation. Our objectives at Lancet Migration are to not only undertake and support high quality multidisciplinary academic research to address gaps in evidence in migration and health, but also to bridge the gap and to stimulate public participation, advocacy, and policy-making activities to transform evidence into action at both local, regional, and global levels. And this we achieve through our focus on priority research themes, which include our current global research projects on universal health coverage and migration, climate change, migration and health, and COVID-19 migration and health system response, but also via our Lancet Migration regional hubs, through which we aim to form consensus around local and regional priorities for migration health research and translate global priorities into community-based and regional level actions. Some of the challenges which we noted both during the Commission and afterwards in terms of research capacity building were that there seemed to be a lack of sustainable funding, with research funding often focusing on shorter term projects of a maximum of a few years. There was an inequity in allocation of research funding, with disproportionate migration health research conducted in high income countries rather than low middle income countries where most migration actually occurs. And also a lack of regional networks with capacity to help define and push forward the migration health research agendas. And via our regional hub approach, these were the areas which Lancet Migration aimed to strengthen long term, creating both regional and inter-regional links between hubs, supporting local institutions and academics to define research priorities in their regions, and also to address research gaps. So I'm going to talk a little bit more about our first regional hub, the Latin American Regional Hub, which formed and launched in Peru in March 2020, and works to raise the profile of migration health in the region and to ensure regional engagement and operational policy impact, as well as creating a strong network to encourage high quality migration health research in Latin America. You can see there some of our Lancet Migration Board members in the Latin American region. They're a multidisciplinary team from across different countries in the region, and they're comprised of experts who are really very dedicated to the field of migration and health, and also to working closely with regional collaborating institutions and stakeholders to form links between academia, civil society, and public policy. And it is really via the direction of these regional board members, as well as implementation through a broad membership base, which we have engaged with research and policy priorities through a series of webinars over the last year or so, but also through encouraging active linkage between both our global work, Lancet migration work, and the regional work. And we're currently carrying out a number of research projects and multi-country analyses in the region. The regional hub is also adapting the recommendations and analysis from the global level commission into the realities and pluralities of Latin America, both reflecting the lived experiences, political and economic structures, as well as many current advances in the region in migration and health. And in this way, through this strong engagement through our regional board members and further members, we hope to foster a paradigm shift in research on migration health, which highlights the importance and the essential importance of the regional and local narrative. We believe that this contextualization in research is very important, as what may work in one specific setting doesn't mean that it will work well in others. And therefore, we've aimed to help to build research capacity which functions in the specific regional context, and to prioritize effectiveness and appropriateness in all of our regional research capacity strengthening approaches. We also have another hub, the European Regional Hub, which is forming shortly and is currently in inception stage, will launch hopefully in March of this year. And we've conducted an initial scoping review on migration health initiatives in the European region, both past and present, which demonstrated that although there are or have been a large number of networks, individual projects and funds across the region, the majority of these do end after an average of 2 to 4 years with minimal, if any, follow-up. And this really highlighted to us some of the major challenges that exist, not only regionally within Europe, but more broadly globally, in ensuring continuity and sustainability within migration health research. This was one of our outputs from the Commission, just showing some of the policy developments which relate to migration and health over the last decades. And despite the fact that there's been a substantive number of policy and research advances in the field of migration health over the last decades, much still does remain to be done in order to realise health for all migrants, and also to strengthen migration health research capacity, and often to bridge the gap between global priorities and the regional and local expertise and priorities. From our experience at Lancet Migration, in order to ensure regional research capacity strengthening, we found it's necessary to look beyond the traditional public health and migration lens and really work at a local level to find solutions and partnerships and to help bridge the global, regional, and local divides between also academia, policy, and practice. So this is some of the work that we have been doing. We are an ongoing collaboration, and we do continue to work in both academia as well as the regional hub approaches in different parts of the world. And it'd be a pleasure to connect with you more through our website or email. And I really look forward to the rest of the panel. Thank you very much.
Thank you very much, Miriam. Thank you also for showing us that this is one of the Lancet commissions that is really following through on its work beyond publication and striving for impact in different settings. And congratulations for your perseverance and leadership in doing that. And we look forward to continuing to engage. I'm sure there's questions coming through, but we're going to wait until everybody's spoken and then we'll take questions. And now it's my pleasure to invite our next panelist, Professor Anna Thorson. Anna is my colleague at WHO and Unit Head Research, Leadership and Capacity Strengthening Unit, the Special Program of Human Reproduction, HRP, at WHO Geneva. She leads the research capacity strengthening work within the HRP Alliance and currently also with research on sexual and reproductive health rights, pregnancy, and SARS-CoV-2. And Anna will be speaking about developing a joint initiative for research capacity strengthening in the context of migration and sexual and reproductive health and rights. Over to you, Anna.
Thank you so much, Kabir. Let me just go to share my screen. Can you see this?
Yes, we can see it, but it might need to be put in full screen mode.
Okay, this is better, right? So thank you so much, Kabir, for the introductions, and also thank you, Miriam, for setting the frame of this session today. I will speak about our joint initiative for research capacity strengthening in the context of migration, and I will also mention a bit about the sexual and reproductive health and rights perspective that led us into this work to start with. There's a very long list of names here which represent colleagues within HRP, our Gender and Human Rights Advisory Panel, colleagues with WHO, TDR, and the Alliance represented by Gary and Kabir here in the session today, as well as our colleagues within the HRP Alliance Hub in Brazil, who has helped us to coordinate and manage this work. So migrants, sexual and reproductive health and rights. We have an unprecedented number of people who have been forcibly displaced in 2019, counting 79.5 million individuals who are exposed to complex social, ethnic, political, and economic hardship. This means that fundamental rights to health are undermined, likewise that sexual and reproductive health and rights are frequently curtailed. There is plentiful of evidence coming from HRP and also partner research, which suggests that across the sexual and reproductive health and rights spectrum, there are considerable access and quality of care barriers related to all and each of these different aspects of sexual and reproductive health and rights. In relation to this, we also had preliminary results which related to the migrant stream from Venezuela to neighboring countries in Latin America from our partners in Brazil and the Roraima state, where there were reports about unmet healthcare needs in relation to contraception, ANC care, postpartum care. Also that there were no possibilities to manage violence and xenophobia, and that very many of these women perceived that violence was present in everyday life for them. This preliminary evidence led us to discuss the need of research and research capacity strengthening combined, and like Miriam also highlighted in her presentation, conducting research where the study population is represented by migrants is a complex and sensitive issue where migrants' voices, perceptions, and experiences also need to be well represented. These type of study populations that face perhaps both legal or other type of societal barriers are stigmatized, and they face access barriers to the formal healthcare system, which means that research also is complex in the sense that research may put in some settings these individuals at risk of identification and hence also legal consequences. This means that it is really necessary to build capacity and to sensitize researchers on a range of methodologies that are available in order to meaningfully address these questions. It also means that these type of research initiatives really need to be locally grounded as well as locally owned in order to conduct this research in a sort of sensible and way that also recognizes and spearheads the sharp research questions that are needed. So the way we work within the HRP Alliance in relation to research capacity strengthening is that we work with a wide variety of different partners and different modes for promoting research capacity strengthening. In this work, we have specifically worked together with our WHO colleagues, of course, and then also with our HRP Alliance hub in Latin America. And we have worked with targeted special research grants. We have in this work together with the Alliance for Health Systems and Policy Research and the Special Program for Infectious Diseases of Poverty, TDR, acknowledged that our respective research portfolios are indeed closely linked and in the case of migrants and health also often intertwined. There is no good research related to access to sexual and reproductive health services that doesn't take in the health systems questions. For example, STIs and HIV, health systems needs and other types of infectious diseases prevalent in the areas are further linkages that exist between the programs and which, in addition to the joint perspectives on research capacity strengthening, merits this joint approach to the portfolio. We also acknowledge that the context-specific and locally led research is necessary in order to mitigate health disparity and knowledge gaps, and that we need these aligned approaches in order to really cover the research continuum, which covers both the whole pathway from research evidence generation to potential policy and actual implementation and practice. We have used several guiding principles underlying the work that we do together. And this, like I mentioned earlier, is very much related to the concept of locally obtained and owned data, which contributes to also reduce power imbalances in global health. This has been important to us in all of this research capacity strengthening work. We also recognize that gender and human rights concerns and concepts are critical, and not the least if we want to change policies and practices, these guiding principles need to be observed. And we have also joined around the model of working where we have a lot of responsibility provided to the regional leadership through the HRP Alliance hub, where they have been able to regionally take leadership and support effectiveness and local ownership of the research capacity strengthening efforts. So we launched a call in 2019 for small grantees, and this work was between our 3 programs. In addition, together with the Pan American Health Organization, PAHO, and also, like mentioned, the HRP Alliance Hub with Unicamp Campinas in Brazil. Following this call, 12 research projects were identified and are currently in the process of working on their projects with some small delays in relation to the COVID epidemic, but most projects have actually been able to already start, which is very great. This call was shared openly and promoted very much in local networks, and also shared and promoted in English, Spanish, as well as Portuguese. And we used standardized assessment criteria for proposals, where we took special care to also assess that gender and social equities were embedded throughout the research questions and also the planned implementation. We also, since these were embedded activities with a research question together with the research capacity strengthening, we also wanted to ensure that proposals actually had a plan for research capacity strengthening activities and wasn't just a learning by doing, but had a little bit more ambitious features than that. And the HRP Alliance Hub in Campinas then was mandated to support the local research teams, and they were also guided to work in gender balanced research teams to support and mentor the individual researchers, and to strengthen the full processes of protocols and implementation, all the way to supporting knowledge translation of evidence at the final stages. So the final lessons learned from this joint venture, or sorry, not final lessons, but perhaps interim lessons, are that the research capacity strengthening must be actively addressing gender and social disparities in the distribution of research capacities and resources. The migrant and refugee voices are frequently unheard, and women and researchers located in LMICs are underrepresented, and this we need to counteract and continue to counteract. Strengthening research capacity together with conducting research can deliver both on required information and data, and also support the creation and sharing of knowledge from those that are most affected by the migration crisis, as well as combating at the same time inequities in global health research. We are looking to consolidate this process in Latin America and see to how we can expand to other regions, working in similar models and taking stock of the lessons learned so far. Thank you very much. And for those interested in more information about the HRP Alliance and our work, you have the link on this page. Thank you so much for listening.
Thank you very much, Anna, for sharing that work, the joint work that we are doing, as well as the focus on SRHR and sexual and reproductive health services by the HRP Alliance. And as you pointed out very nicely, the presentation focused on sexual and reproductive health services, but also highlighted how the needs of vulnerable migrants are indivisible from infectious disease issues and from broader health systems concerns. And they really need context-specific and locally led research to address. I think also a really important point on the importance of research being focused on rights and justice, which is also one of the themes of the Health Systems Research Symposium. And so it integrates nicely with that. So thank you very much for that presentation. As our next panelist, we have with us Dr. Joe Berry, who is Associate Professor and Director of the African Center for Migration and Society at Wits University, and Vice Chair of the Migration Health and Development Research Initiative in South Africa. With a background in public health, Joe's interdisciplinary research focuses on the intersections between migration and health. Over to you, Joe, for your presentation on the creation of the Johannesburg Principles, Guidelines for Ethical and Equitable International Partnerships in Migration Research, and how these can be applied to research on migration and health.
Great, thank you so much. And thank you to everyone who's joining us today. Just to check, you can see the slide that's up at the moment. It's essentially blank. So that should be there. So what I wanted to do—
slides, Joe.
Pardon?
We can see two slides next to each other.
Okay, is that better now?
That's better.
Brilliant, thank you. So I wanted to take the time to talk about 3 initiatives, which I believe talk very well to work that, for example, the UCL Lancet migration group are working on, and the work that Anna has just shared. So there's three initiatives, some of which focus on a more global perspective, and another initiative which focuses very specifically on the African continent. The first that I'd like to share with you is the Migration, Health and Development Research Initiative, MARGERI, which is a initiative that was set up with the aim of supporting the advancement of evidence-informed global migration and health policies, practices, and so forth. And the idea is really providing an open platform. There is no membership fee, for example, a platform that will facilitate collaboration and connection between people from various sectors working in the field of migration and health research. There is an aim on drawing together individuals from lower middle income country contexts. And that's for a range of the same reasons that Miriam was talking to, for example, around where we know the biggest gaps are in what's being produced in terms of what is being seen by a global audience. And part of the initiative is aiming to bring to the fore the voices and the opportunities for low middle income country early career researchers, as well as people early in their career in other sectors who are working in the field of migration health research, to gain support, mentorship, and so forth. And I encourage you, if you are interested, to please take a look online. There's currently just over 150 member profiles that are searchable online, and a range of other initiatives. One of the key activities, which again, I think talks to some of the work that Miriam was discussing in the European context, is a global scoping that is looking at the various migration and health training initiatives and capacity building initiatives that are taking place at the global level. And we will soon be launching an open access searchable database that aims to provide some open access resources for anybody who is interested in accessing existing training and learning materials, as well as connecting with other spaces. Secondly, I wanted to briefly talk about the African Academy for Migration Research. This is an initiative that is a 3-year program working to support the next generation of African migration scholars. It is part of ARUA, the African Research Universities Alliance, of which our center is a center of excellence in migration and mobility. One of the thematic focus areas is migration and health. And the AAMR has 2 overarching aims. Firstly, to build the research capacity of the next generation of African migration scholars, and secondly, to support continued professional development. And this is to be achieved through 2 key aims. Firstly, what are now virtual institutes that will take place over a 10-week period with 1 session per week, a combination of thematic input from experts working predominantly in LMIC contexts, but also elsewhere, as well as continued professional development opportunities. All resources that are produced will be made available open access under a Creative Commons. Second to that is a small grants program. One of the biggest challenges that we're very aware of on the continent is the lack of funding for African-driven and African-implemented research and research program development. So the aim here is to be providing funding that is specifically for scholars based at African institutions to undertake research and network building, capacity building, professional exchange in ways that will support them in their career, as well as their home institutions. Obviously, the initial aim was for as much of this as possible to be in person. Everyone, those plans have changed. And I think we're going to see in our context travel restrictions for a far longer period. So we are also working with colleagues elsewhere to explore learning and delivering a various range of collaborative platforms for both the development of curricula in a collaborative way, but also their delivery. And finally, I'd like to take the last minute or so to share with you another initiative that our centre has been part of, and work that is coming from that includes partnership between our university, Wits University in South Africa, as well as UCL through colleagues both at the both Miriam, for example, and other colleagues in London at the Migration Leadership Team project. In this programme of work, that involved a series of collaborative workshops across various contexts. A series of global migration conversations were held in a range of locations, including Delhi, Nairobi, New York, Beirut, Glasgow, Thessalonica, Medellin. And I'm sure that some of you here will have participated at one point or another. And the principles are reflection, they're a living document, and are an attempt at a reflection of the consensus that was made around what is needed to strengthen research partnerships around core principles of equity, meaningful participation, and shared power in decision-making for good quality migration research. Now, obviously, these are as applicable to the field of migration and health as they are elsewhere. Obviously, there's no time to go through these just now, but to give you a snapshot, here are just a very sort of simple overview, and I'd encourage you to look online, and perhaps during the discussion we can come back to this. But what I'm hoping we can see here is that various principles really talk to the issues that both Anna and Miriam have already spoken about, particularly around power and around the roles of funders in determining research streams. Thank you very much.
Thank you very much, Jo, for introducing those capacity building initiatives, which are unique in the Global South leadership that is demonstrated as well. And also the importance of equitable research partnerships, which surely goes, as you mentioned, beyond migration research to relate to all health research and development research. And there are broader issues at play there, which we need to tackle. And so thank you for bringing that up. I wish we'd had the time to go through some of the principles that were outlined and a magnifying glass to look at those, but I'm sure that we'll have a chance to engage more on the Johannesburg principles as well. So next we have the speaker, Professor Julian Fernandez, who is Doctor of Medicine and Master in Public Health, and Professor at Universidad del Norte and National Director of Epidemiology and Demography at the Ministry of Health and Social Protection, Colombia. And Professor Fernandez will be talking about country experiences from Latin America, the creation of a National Observatory of Migration and Health in Colombia, implications for migration health research. Over to you, Professor Fernandez.
I'm very glad to be here. Thank you for having me. I'm going to share my screen. I have some slides. Can I share my screen? Yes. Okay, give me a second. Okay. Do you see my screen?
Yes, we can. Thank you.
Okay, thank you very much. I'm sorry because my slides are in Spanish, but I'm gonna speak in English so that I didn't have time to translate the slides. Excuse me. Okay. Well, Colombia has historically been characterized as an sponsor country. Certainly, in the last years, we started to be a receptor country. It has become a transit country over the recent years and the main destination for migrants from Venezuela. Over 2 million immigrants are estimated to be resident in Colombia right now, making it one of the countries in the world with the largest number of immigrants. This population increased over the recent years with over 1 million people who primarily came from Venezuela. Roughly 19% are from Venezuela. Next, a total of 15–60% of migrants in Colombia has an irregular migration status, and 5 million entered the country temporarily to work, study, purchase supplies, or receive healthcare, not counting the returned Colombian population. In this context, a need has arisen for the country to make regulatory change in order to receive and help the migrant population, as well as to ensure access to basic social service for their well-being and in consideration of their human rights. These changes has focused on the legalization of migrants, access to health service, access to family welfare service and early childhood support, access to education, and specialized health care for the vulnerable older adult population. Okay, next. So, one of the greatest challenge for decision makers is having pertinent and reliable information. In December of the last year, the Ministry of Health and Social Protection initiated the country's first National Observatory on Migration and Health to develop a knowledge scenario based on systematic observation, analysis, investigation, knowledge transfer, and interinstitutional collaboration as the input to identify needs and masking key public policy decisions. This observatory also provides decision makers, academics, the community, migrants, and other key actors with reliable and timely information that enables formulating, executing, monitoring, and evaluating public policies aimed at the social inclusion of the migrant population. The National Observatory on Migration and Health reflects an information management scenario in which different actors, approaches, and methodologies come together. It identifies and provides source of information, conducts qualified and relevant analysis, and promotes multidisciplinary, intersectoral, and interinstitutional work through 5 thematic areas that focus on the characterization of the population, the health situation, access to health service, violence, and public and regulatory policies. The purpose of the characterizing the population is to provide descriptive analysis using quantitative and qualitative data, as well as primary and secondary source of information in order to gain knowledge and understanding of the structure and dynamics of the demographics and his distribution throughout the country. The National Observatory on Migrant Health is interested in the identification and monitoring of affiliations with the general social security health systems and effective access to promotion and prevention health service, as well as treatment, healing, and the rehabilitation of the migrant population. In addition, having a diagnosis of the health situation and the multidisciplinary process with which to describe and analyze the concrete health illness situation of the migrant population are key to providing information that enables identify the health needs of the population. To this need, the following thematic sub-areas have been established: infectious apparatus disease, chronic non-communicable disease, sexual and reproductive health, mental health, child and maternal health. Okay. The observatory is also interested in offering a place where causing regulatory documents are made available so that the key actors such migrants, academics can find the underlying policy and regulatory framework between the migration and health framework. We really consider that this is a novel approach for a country as Colombia, one which is aimed jointly building and sharing knowledge, and making it possible for the conception of the migration population to go beyond to an object of analysis by getting to know migrants as subjects who have rights and the ability to manage their health, with also incentivizing their social inclusion in the country. I'm going to show you the webpage that we have, in which you can find is the webpage. I can share the link. You can check. Thematics. So this is not working.
Professor Fernandez, are you there? We lost you briefly, Professor Fernandez.
Yes, yes.
Yeah. Please continue.
Colombia is right now the main receptor of migrants in Latin America, and we really want to share this experience with you. I am going to send to Miriam the link to the Observatory. We have a lot of different data, and as well as the publication of our group. And we really consider that this information could be used to build a health policy for migrants in Colombia, the first health policy in this country. I'm so sorry because I didn't have enough time. You know, we are facing a pandemic. I am the director of epidemiology, but that is something important for Colombia right now to include the migrants in the response. So sorry for the presentation, that maybe it's not working everything, but thank you very much.
Thank you, Professor. Please don't apologize. We know how busy you must be, and thank you very much for making the time to come to this session and present some of that work. And a very inspiring example of country leadership in acknowledging the distinct importance of migration and health, and also in data visualization and data-driven practices and policies. And I also wanted to highlight the link between researchers and policymakers that you mentioned. And I believe you yourself have bridged both of those roles. And that's another key area that some of the other panelists have also commented on, the importance of strengthening national research as well as research use capacity. So thank you very much again for your presentation. And we look forward, we hope you will stay with us, and we look forward to the discussion. And with that, I will now hand over to my colleague at WHO, Dr. Gary Aslanian, who is Manager for Partnerships and Governance at TDR. Dr. Aslanian manages the partnerships with global stakeholders focused on research for health. He has taken on various roles in leading organizational and technical innovations, and he is a recognized leader in public health globally. Over to you.
I hope you can hear me. Thanks,
Yes,
Kabir.
we can't see you though.
You can't?
No.
Oh, okay, that's interesting because I see myself there. I will.
Well, if you see yourself, please continue. Maybe it's at my end.
Oh, I'm not sure. Oh, okay. Can you see me now? No?
Yes, we can see you.
All right, great. I'll go ahead. Thanks, and this is really super great, and an opportunity to discuss this, and I'm looking forward to the questions and later part As my colleagues, both Anna and Kabir mentioned, TDR has been working on capacity building, especially focused on tropical disease or the infectious disease of poverty for many years. And the issues of refugees and health of migrants, or health of refugees, migrants, and issues around migration is probably not a new thing for us, obviously, not for least because a lot of the work that we've done focused on infectious diseases, and you probably know that for sure when it came to big three, HIV, TB, malaria, and outbreaks of various diseases, the migrants as making part of key populations for these diseases have been always an issue that came up. We may have not had a more separate kind of a program around that, but we have always had that integrated within our programming. Now, it is partly difficult to plan for something we don't know, and I'm hoping at the end of this session we'll get a better sense, and or with the Commission and all upcoming spotlight put on the issue, we can better understand the gaps and then plan specific research projects that will then help us focus on that. TDR has, in the last at least 8 to 9 years, been focusing more on implementation research, meaning that we are focusing on looking at how various health interventions have worked out, or how they had impact, or how they are not catching the populations that need to be, their issues, health issues need to be addressed. And again, migrants are key populations for such diseases as HIV or TB. We had projects that focused on migrants and refugees from Afghanistan, in Iran, or other countries in the Middle East. A lot of that was focused on TB, and it has been a major barrier on effective control of TB in the country and the region. Then you have obviously migrants that are between countries, but are migrating for work, for seasonal kind of work, where let's say in South Africa, you have miners that are exposed to greater TB while working in the mines, and these kinds of projects were part of what we focused on. So long story short, it is also important to reflect on, and I'm hoping that we can do that, is that when we talk about research for priorities for research or capacity building, the capacity building issue really comes very front and center, because at times there isn't a capacity in certain parts of the world, certain regions, or there is capacity for research, but it's not really geared towards implementation type of research that has to be linked to the current challenges facing the health system. So for that purpose, several times when we had calls for how to address issues of migrant health within broader calls, the main barrier has been actual capacity in countries to conduct that research, conduct that kind of implementation research. And something to put on the table to help us think about it, there are different phases and parts when it comes to migration or to this key population, including different types of research capacity that is needed, because before migrants become migrants, the kind of health issues are or the needs are of different type. Then there is actually the phase when they move, and a lot of cross-border or other issues come up, and issues focused on outbreaks, refugee camps, etc., travel conditions. And this is maybe a different kind of research, and has to be field research. So you really have additional complexity added to that. And then, of course, there is also the arrival at the destination for work, or as refugees, or as other type of migrants. A whole set of anthropological, language, culture, other separations from family, and other compliance with treatments that they are receiving before, especially when it comes to infectious diseases, which is kicks in. So in this whole process, I hope we need to kind of recognize the different types of capacities that are required, and only through that we'll be able to conduct quality research that will give us the real picture and evidence of what are the options in front of us. One additional point at the end to mention that when we're doing implementation research, a lot of it is also could be done by using existing data, meaning that sometimes there's data in gray literature or in reports of agencies that are relief agencies, or they work on immediate sort of issues that are facing these populations, and they don't think of it as research worth kind of data. However, with those who are able to search and use existing data could also add to this, especially in places and situations where actual kind of field or research on programs is difficult or impossible, or very hard to conduct, or has security and other issues. So there is that particular skill set that is required to add to this kind of implementation research in the mix. So I would probably conclude here, stop, and really looking forward to further discussion on this, because as Anna and Kabir mentioned, we have one program currently focused on that jointly, and we will be having more in this area, and within WHO there is more focus on this. So I think we can really help with this session to set some priorities that we can all then use. Thank you very much. Over to you, Kabir.
Thank you very much, Gary, for that overview of the work on implementation research and raising some really important points there. Especially, I thought very important was research that the fact that existing research capacity is often not suited to the issues facing the health system, and how research capacity strengthening efforts will need to be directed in ways that build capacity that is relevant to change, and not in other areas. And we see this particularly in low and middle income countries. Certainly my experience from India, that we are very heavily focused on strengthening disciplines, but not on interdisciplinary and applied research capacities. So that's a crucial area for change. So thank you, Gary. And with that, I'll now hand over to my friend and colleague, Dr. Fouad. He is an associate professor and co-director of Refugees Health Program at the American University of Beirut, Lebanon. His research interests are health systems in conflict contexts and fragile settings. And he will be speaking about building research capacity among refugee health workers in contexts facing multiple intersectional shocks. Over to you, Dr. Fouad, with the final word that your biography is very modest and doesn't really reflect the inspirational figure that you are. And it's an honor for us to have you on this panel.
Thank you, Kabir. Yeah, it's an honor to be with you, actually, and thank you for this introduction and for having me in this with this wonderful colleagues and friends. First I will now set my timer just to be sure that I'm on time. And also, I apologize, I don't have presentation to carry. I may show some picture and just to protect you from seeing my photo for this 6 minutes. Well, I will bring my experience actually as health workers, health professionals that move because of war. I'm Syrian origin. I displaced person myself, displaced health practitioner and academician, moved from Syria to Lebanon. So I want to reflect on this experience, but also I will try to bring the issue of what does it mean, working in fragile settings like in the region in Middle East, and how to how to integrate migrant and refugees' health in the national health system, especially in such a sort of conflict-affected settings. And I will focus specifically on the importance of building the capacity of not just migrant health workers, but also forced migrant health workers to improve the quality of care for refugees, displaced population, but also for the host communities. My example will be from Lebanon, as I live here and work here, but also I will expand, my actually scope into the region, but maybe beyond that. Just to tell that, as you may know, all of you may know that in August 4th, 2020, a massive explosion in Lebanon, in Beirut, killed 300 persons and injured more than 6,000 and left 300,000 people homeless. That's just in a few minutes, almost 40,000 housing units, destroyed. At that time, COVID was hitting the country and, sent many people to ICUs and to hospitals. But it wasn't like only COVID and the Beirut blast. It added to the issue of severe economic crisis that starting from 2019, that led to devaluate the Lebanese currency by 80%. But again, this is not the entire story. So, Lebanon is a small country of 5 million. This country hosts the largest number of refugees per capita, with almost 1.5 million Palestinians and Syrian refugees, but that's since decades. So since 5-6 decades for Palestinians and since 10 years for Syrians in Lebanon. And Lebanon itself, is sort of experienced non-stop crisis for 40 years, starting with civil war and not ended, unfortunately, with this massive explosion and blast. This crisis exposed the issue of the underfunded, understaffed, and overburdened public health system, and put a huge burden on the system itself. The health system in Lebanon is fragmented, into national health system, system for of UNRWA for Palestinian refugees. There is a sort of a system for Syrian refugees that work with the Ministry of Health, but also there's what's called now informal health system that served for refugees and by refugee health workers. This characteristic of the system actually is the fragmentation added to the issue of difficulties in navigating the system itself for refugees, but also for the vulnerable population. The system is very privatized. In Lebanon, refugees are not allowed to work, as Lebanon is not a signatory of the 1951 Refugee Convention. Syrian and Palestinian health workers have no permit to practice. Therefore, actually, we're ended up with having a huge burden on the system itself. As you may know, that historically in the region, healthcare, and maybe beyond the region, healthcare for refugee population has been provided primarily through dedicated health clinics located within refugee camps, that was the model for Palestinian refugees run by UNRWA. But unfortunately, this is not the type now of serving refugees. We have now sort of non-camp. People are living in urban settlements, mainly talking about Syrian refugees, but even Palestinian refugees living in urban settlements. They are not anymore in camps, and they are actually integrating with the host communities themselves. Anyway, so if the goal is to adapt to serve those people, if the goal is to adapt towards universal health coverage in context of protracted conflict like in the region and forced displacement, fragility, so there is a need to respond to these fundamental questions. So one is how to define universal health coverage in health system context facing multiple intersectional shocks, challenges and vulnerabilities, like the one in Lebanon. Second question, what are the barriers against universal health coverage due to specific identities? We're talking about non-citizen, immigrants, refugees, asylum seekers, stateless. So we have, what about, those different identities, and what are the barriers to apply this universal health coverage? And third question is, what are the interfaces between formality, whether it's a national system, health system, or the international organization? What are the interfaces between the formality and informality in health system response, considering vulnerable identities? And the last question, maybe the last question, could be, what are the political economy aspects and the role of state in expanding the concept of universal health coverage actions among those excluded population group? I will just give an example about Syrian health workers in Lebanon that face several challenges here. They are, certified from Syria, moving here. First, problem is they are not allowed to work, and because the entire Syrians are not allowed to work in Lebanon, so they need to have the authorization to practice. Therefore, there's a threat of closing centers that they work, or clinics, and threat of losing their residency status, let alone actually deportation that happened in several cases. The other issue, the other challenge, is the declining of their skills and knowledge as a result of being illegal workers and cannot benefit from any capacity building or training program. In fact, data show that by engaging those frontline migrants and informal health workers in making change to their care processes, the quality of health services can be significantly improved. This engagement gradually brings a cultural shift in understanding the roles and capabilities of those frontline workers, as well as their confidence and motivations. There's a need actually to provide adequate funding and appropriate research to support capacity building for those refugee or migrant health workers, and to integrate them in the mainstream system, especially in time of emergency and what we see now, this shortage of health workforce in this pandemic, and even not just because of pandemic, because of this political instability. Many Lebanese health workers themselves left the country. Makes the needs for health services actually in dire position. But before all these issues, there is a need to understand and maybe to include the political determinants that affect the engagement of migrant and refugee health workers and their contribution in the host countries and communities. I will stop here. I think I'm one minute past for overtime, and thank you very much for listening.
Thank you very much, Fawad. So I think the Lebanese context is clearly, especially when dealing with migration, is unparalleled in the world. And thank you for pointing that out. And it's almost unimaginable for somebody who's not in that context to understand the strain on the health system, especially given the constraints that you mentioned. And also that it's a long-standing issue as well as an acute issue. I think this is something that it's a unique mix, because people often associate migration either with economic migration over long periods of time or with acute forced migration. But this unique context, I'm sure, creates a very unique set of challenges. And you've asked and posed a series of hard questions, which are, I think, very excellent research questions, but they also go beyond research questions and are simply hard questions for us as the global community, health community, about universality, universal health coverage, vulnerability, responsibility and accountability, and the political determinants of migration and health. So I don't think we will be able to answer all of those in this session, unfortunately, but we can try. And we hope to try and get to the root of some of those in the next session. So thank you again, Fawad. And I think we're a little bit over time. So I think we should move straight on to the next part of the satellite session. And I can hand over to my co-chair, Dr. Jocelyn Clark. So Jocelyn is executive editor of the Lancet UK. She's a Canadian national public health scientist and a journalist. And over to you, Jocelyn, to chair the forum, which is the second part of the satellite session here today.
Great, thank you, Kabir. And then thank you everyone for sticking with us, and thank you all of our wonderful speakers in the first half. So we can remove this slide share, please, and bring our participants back together, and we'll have a panel discussion. Thank you so much. And really, I kept thinking over the course of your wonderful presentations, the ways in which this sort of divide in our session between the local and regional versus now moving into some discussion about a global agenda for research capacity building, in fact, is a bit artificial, because so much of what you described in terms of your own institutional and local and regional experience certainly, demonstrated that the impressive work that's being done that really ought to be scaled and all of us can learn from. The principles you described, the ways that you've collaborated and brought in multidisciplinary experts, migrants themselves, thought deeply about working in difficult contexts like conflict. These are all lessons that must populate. In fact, they must drive the global agenda. I'm sure you agree. So let's talk about that over the next few minutes. And this is where I also remind the audience and invite them to please ask questions to our presenters using the live Q&A panel on the right of your screen on the conference portal. I'm not seeing any questions there quite yet, so I'm going to kick us off with a few questions that I had pre-prepared for our panelists, but I will interrupt over the course of the next few minutes if we have questions from the audience. So I very much invite you, please, participants, to ask any questions to any of our panelists. Thank you again, all of you, for joining, and I look forward to our conversation over the next few minutes. So I would like to start with you, Kabir, if you don't mind, having done such a wonderful job of chairing our previous session. I thought I could pose a question to you to really kind of set the tone for our session. Let's kind of use this time that we have, this precious time, to think about some practical steps we can do collectively. So having learned all that we have so richly from our colleagues about their perspectives and the work that they're doing in country and beyond. From your point of view, what do you see as being the perhaps top 3 most important mechanisms that we can harness and collectively develop to advance a global agenda on building research capacity in migration and health? And please, if you would, keep your responses short, to under 2 or 3 minutes, please.
Sure. I'll try to do that, capture a global agenda in under 3 minutes. I'll do my best.
I want your top 3 mechanisms. I'm sure you have 30 of them.
No, I will keep it short. Okay. So I won't try and summarize what everybody else has said, because I think there's a concluding note as well, and I'll try and do that there. But I think it's been a great set of discussions. There's a lot of variation, but a lot of unanimity as well. There's a big spectrum of what we've been talking about. I think one thing that's very clear is that research on migration and health cannot be only the concern of a few well-meaning and interested people in the global centers, but it really needs to become a much broader pursuit. And we need to overlay our understanding of migration and health onto this broader issue of how knowledge is produced and used globally, and how that's often skewed. And it's also not often useful for the change that we want to see in health systems. So that really, we need to fundamentally address that. In the first place, I think we need to be clear that there are some themes that resonate across the board when we talk about migration and health research, like inclusivity, universality, vulnerability, portability of information, and practical issues like that. But there is really no one universal agenda on migration and health. And ultimately, the issues are always going to be context specific. We heard the Lebanese example is very unique, and I don't think there's any parallel. So we need local expertise to address that, both local expertise in terms of local research expertise, but also local research expertise that's embedded in the local health systems context and it follows those sort of co-production and embedded approaches to tackle. So we need to find ways of doing this. I mean, some of us at the Alliance, WHO, our partners here, we've been focusing on advancing embedded research, which is really about research undertaken as part of decision-making in health systems. And in close collaboration, we don't make a distinction between research, knowledge production, and action, and that's all part of the same continuum. The role of health systems is key in generating and using evidence to address migration and health. So that's certainly one mechanism. Another issue would be that migration research is a very complex domain. It's not really, human mobility is something that is very basic to human beings. It's not something that's a niche issue, and human mobility, when it gets overlaid onto other human concerns, the concerns of migrants are not separable from the concerns of other vulnerable people always. And migrants are often among the most vulnerable people themselves. So as we've seen, migrants are especially prone to neglected diseases of poverty. They're especially prone to difficulties in accessing sexual and reproductive health services. And so their concerns are not always different from those of other vulnerable people. And for a complex and multifaceted subject such as this, we need skills in interdisciplinarity and being able to work across disciplines, but also transdisciplinarity, being able to work with different stakeholders. So that's another type of capacity that we need to strengthen, especially in low and middle income countries. And funders can help, but ultimately governments must also start investing more in this sort of transdisciplinary and interdisciplinary and applied research capacity. And finally, and I hope I've stayed to my 3 minutes, we need to go beyond looking at health systems as being geographically bounded jurisdictions. We really need to start thinking about health systems as people-centered. Somebody mentioned that earlier. People-centered health systems, very aligned with WHO's framework on people-centered and integrated health services. Health systems are made up of people, and mobility is a fundamental and basic activity of humans. So migration is a basic human experience, but also epitomizes human vulnerability. Migrants are often the most vulnerable to economic, epidemiological, and ecological catastrophes. So we must go beyond our perceptions of health systems as being jurisdictions and start to really reimagine them as being people-centered. And that would be my third lesson. Over.
Thank you, Kabir. I like how your three broad mechanisms really chimed well with some of the themes that I took from the presentations of our colleagues in the first session. I want to take those in turn. The first one really speaks and resonates a lot about the ways in which power and power relations operate within this space and present, in fact, the foundation for many of the challenges that have been described. And I want to go to you, Joe, if I can first, partly because I know all of us are anxious to learn more about your Johannesburg principles, because they, in fact, you may believe, as we hope, that those could be a tool that could be deployed more broadly or more globally. But can you answer the specific question about confronting power that has been touched upon so far today? To what extent do those principles around the ethics and the collaborative nature of partnership within research on migration and health, how do they help confront the power differentials we're hearing about?
Thanks so much. Thanks for the opportunity to talk a bit more about principles. I think firstly, it's just important to acknowledge that whilst the principles are known as the Johannesburg principles, that was because they were drafted after a process that took place over an 18-month period at a final workshop in Johannesburg. So just to emphasize that this has been a global process. You know, in many ways, this is the big tension, right? Is power is, as we know, it's at the center of everything, and it's not something that will be resolved or solved in an easy way. But the ways in which the principles have really encouraged us to think about where power fits is foregrounding it. So foregrounding it in many ways, and particularly looking at the value of local research and existing knowledge, whose knowledge counts, whose voices count, and recognizing, linked to that, the ways in which funders and potentially other well-meaning colleagues in other areas can come in with particular priorities, suggesting that those particular needs that have been identified already by skilled individuals on the ground that get reshaped. So there's something really important about everybody needing to recognize the power that they're holding over funding. Funding we see as a very central challenge in this debate. And then it's about understanding that power isn't static and we can bring and use our power in different ways. So if I'm a funder, the power I could bring is either to disrupt what's needed or try and reshift my funding streaming to address and meet the needs that people are identifying in these various contexts, for example. So I could use my power for good, as it were. If we are working with international collaborators who perhaps are individuals who hold the funding from joint fundraising proposals, there's a couple of things. It's the power in how that proposal was developed. All too often, individuals in LMIC contexts will be contacted late in the day to come in as a partner to meet a funder's requirement for having partners in different contexts. It takes a long time for a research center or an individual to get to a point in their career where they can start saying no and recognizing that they hold the power to that space. But when you're an earlier career researcher, when you work in a research center that is dependent on grant funding and cannot physically afford to say no, that power can be really abused by those who hold those grants. So there are other ways that colleagues in those spaces can work, and you can develop partnerships and networks more informally out with of a funding proposal space, where there is an acknowledgement that the way, for example, a funding stream is developed, we need a partner in Canada, in the UK, wherever it might be, to hold the grants. But there's a recognition that it is driven in true partnership with individuals in other spaces. Getting to that point of partnership takes time, and it's about soft diplomacy. I don't know if that's the right word, but it's about being in a space where you can start trusting each other. I definitely benefited at the beginning of my research career, including during my PhD, with having mentors more senior to me who had established partnerships over the years that I could then start forming into that network. So it's about trust. And I think that the final thing is probably power in terms of recognizing at the local level within many of our institutions in certain contexts, the way that institutions function is there's power within those institutions. So for example, the way that money is mismanaged potentially in a certain space, the way that senior colleagues who weren't involved in developing funding proposals can jump in and take ownership of that, the way that we might see PhD students, for example, abused in certain ways. And whilst this is a global issue, we know it can be particularly challenging in institutions that are still busy developing systems and accountability structures. So in a way, it's sort of that power that plays out across. And how do we get to a point where we can collectively recognize at the local level, people have the power over the space and the knowledge and what needs to take place. But at the international level, we still sit with funding and policy directions that don't necessarily meet what's needed on the ground.
Thank you, Jo. That was really, really insightful and interesting. And it inspires a further question that I want to put to you, Fouad, because you've had many, many experiences working within international partnerships, and you obviously bring a wealth of experience from your particular context. What are some practical lessons and requirements do you think that those of us who work within institutions based in high income countries that are, you know, to a large degree, really, really interested in partnership and supporting and leveraging and amplifying and building capacity in migration and health research. What are some of the practical steps and lessons and frameworks do institutions from the global north, for example, need to be thinking of? And I mean things as, you know, sort of practical or pragmatic as authorship guidelines. You wrote, I think, a piece in the Lancet just describing that aspect of accountability. Can you give us your sort of top 3, let's say, pieces of advice in terms of lessons for high income country partners and collaborators?
Well, thank you a lot, Jocelyn. I don't know if I have 3, maybe I have less or more. I mean, but I like the number 3 to move around. First, I think there's a real need now to have a real partnership. You know, it's we keep talking about partnership and having like a, you know, globe south and north, and you know, but to be honest, with very few partnership with the very fancy institutes are done, you know, in the region. I'm talking about the very good institute that I work in, but AUB, for example, is something in a different level from many other academic institutions and local organizations, that the, you know, the barrier of language, the barrier of sort of understanding the system of research, how to, or grants, or you know, how is very difficult sometimes to be in. So I think there's a need to build such a sort of capacity in a way that, yes, people in their you know, local, national level can lead. And although that we see many steps now toward this goal, but I can bring many examples about how the money, the research money, still go to big institutions and universities, comparing with the money that goes to the to low middle income countries. So I think that we need to have a different paradigm of this partnership, and that could be something that by itself is a topic for research, how to do that, how to activate this sort of partnership, but in a different way. Second, And I think there is a role also. Kabir mentioned something about the uniqueness of Lebanon, in such a sort of complexity, to say, in a different crises. But I would say, no, it's not very unique. When you look into the region, the EMRO region, for example, here, that hosts 55% of the entire forced migration in the world. And in this region, 12 countries out of 22 now are suffering from either active war or political instability, or hosting a huge number of displaced population. I think there's a need here to also understand such a sort of super long, to say, crisis, which is still away from the way we respond to that. We keep thinking about crises as a sort of emergency or acute, or to some extent is something like a way to negotiate for a timeline, then we go to another crisis in the world. I think there's a need now to think differently about public health in a conflict settings, which is not something as a sort of an emergency or something that in a part of time. It is a context sometimes for decades, and in case of some part of the region, it's 7 decades or 8 decades. It's a huge. So there's a need now also to different paradigm, different approach, different concept of public health in crisis. It is not the same of what we do and I think this is a global issue. It's not just in the region. The third one, which is I see there's a need to focus on, is about this issue also of, Kabir mentioned that when talking about health system, population-centered framework. And I strongly agree that we're the current framework that we have also to work on health system on the people on the move cannot be applied in that context. People are moving in a large number, not just forced migrants, even the economic migrants. People keep moving, and I guess the current framework cannot address that sort of mobility. So maybe also there's a need to see how we can not just bring the attention, but how can to work on more than setting or even region. I think this is a global issue that can be a new way of thinking, and can revolution a bit the concept of public health for people. I will stop here.
Thank you, Fuad, for the wonderful response and just really nailing it in terms of some of the challenges we have. I want to sort of also now bring the migrant voice into the discussion, which was another theme that came out of all of your presentations. And if I could first go to you, Anna, and then to you, Gary, with a sort of similar question. So Anna, you described to us your incredible work across different programs and entities to build alliances and to really highlight and amplify the particular vulnerabilities of women and children and those who are at risk of violence. And you described those situations and building research capacity and undertaking research with those populations as being both complex and sensitive. I wonder if you could tell us a little bit more about the principles that your group has developed, which you shared with us. And in particular, how have those been received? How do colleagues who are active researchers in the field, to whom you're intending to change practice, to try to teach them to embody a more ethical, perhaps a more feminist women-centered approach to looking at vulnerabilities. How have those principles in your work been received in the field? And what would be the next steps in your view to try to scale those and have them be incorporated and more visible in the global efforts to build research capacity? I think you may be on mute, Anna. Okay. I'll ask our tech colleagues if they might try to unmute Anna Thorson, please. Try again, Anna. There you are.
Can you hear me now?
Yeah, we can hear you now. Thank you.
Okay, I'm sorry about that. Thank you so much for an illuminating discussion so far here, Jocelyn, and for the question. Much appreciated, and a difficult question also, I must say. And also being very humble about this, that this work that we do here in the migrant population is very much work in progress, and where we're still learning and developing our strategies together with our partners. So a few things that we take care to do is that in relation to the research projects that we plan where this specific population is involved, we are really looking to find ways to work with participatory methodologies. And this is incredibly difficult, as you all are aware, related to sort of the challenges and sometimes sort of clashes a little bit between the traditional high quality scientific design where an ideal study, our gold standards are the cohort studies or the RCTs if we're looking at an intervention, which all take place longitudinally, whereas here we're looking at displaced populations which in some contexts are indeed facing longitudinal and very long time problems, but also in other situations may be very mobile and without fixed addresses or possibilities to sort of from the start be found to participate in research. So we're looking very much into different types of participatory methodologies where we can instead draw on the situation that exists. And this pushes us indeed towards also different explorative methods, qualitative methods. And we do have two different scientific panels that we work with together with our partners, where we have our specific research project review panel, which is looking at the scientific design and if you like, from a sort of medical traditional point of view, in combination with also looking to see to that values related to gender and human rights and explorative methodologies are present. In addition, we are working very closely with our Gender and Human Rights Advisory Panel, our GAP panel, which is a specific advisory panel that we have to HRP and where we have a lot of expertise who are looking into these specific areas. This is what we do at headquarters and from HRP, but the perhaps most important part of this work is still to work with local partners and for us to take a role as conveners and lifting the questions, whereas at the same time encouraging leadership regionally and sub-regionally and in countries, but also being conscious of the fact that a country address doesn't necessarily mean that these aspects are taken care of. It's a learning process for all actors involved. So we're also working very much actively with our regional hubs as well as with the separate grantees to work on ethics, to work on these different type of explorative methodologies in order to raise consciousness about the different challenges that exist. And also side by side with this, we support very much the regional leaders to promote research governance, because research governance is not is sometimes perceived as a sort of necessary nuisance, but is indeed the cornerstone and the necessary pillar that we need to have in order to ensure that the research that we do is fully ethical and taking our underlying values into consideration. So to this respect, we also work very closely with the WHO Ethical Review Committee, as well as the Regional Ethical Review Committee in the Latin Americas.
Thank you. Thank you so much, Anna. There's so many themes coming from this. I think we could talk all night or talk all day, depending on which time zone you're in. But I'm mindful of time. However, you've raised a couple of things that I'm seeing as a bit of a thread. I mean, an underlying issue is the transformation or disruption of the current world order in migration and health research in terms of confronting and disrupting power relations. I'm hearing very clearly from you all these rich experiences of co-production, of transdisciplinary or multidisciplinary research. And I really wish we had more time to talk more about that, but I know these will be the things that we can take forward. Related to that, Gary, if I could put this question to you, and please answer briefly so that I can have my final question to Miriam before we wrap up. You mentioned during your talk about the mismatch in terms of research priorities, which seemed to me to also signal that issue that both Anna and Fuad and Joe have so far mentioned, which is, you know, not having the right voices at the table, not having migrants themselves, perhaps, or people working at the front line be at the forefront of those discussions and really setting the priority agenda. Can you talk a bit about, just for a couple of minutes, in your view, how we would better set priorities for a global agenda to improve capacity in migration and health research?
Sure. I think well, there are a lot of aspects to this, obviously. One aspect to that is we've talked about not having enough capacity, and that's one way of looking at it. The other one is to ensure that the questions asked or the issues researched, we don't need to wait for researchers to do that. Some people who work in the system or in whatever way they interact with this specific key population, they don't need to be researchers. That's why, for example, we have online tools or other sort of toolkits that, and many of our organizations develop that help the people who work with the population and they know what the issue is, to add that research part. And again, research in quotation marks, because it doesn't need to be, you know, a randomized controlled trial. It can be just a block somewhere in the system, but they don't know why. So from that point of view, using, and I mentioned this, using existing data, analyzing existing data, bringing that kind of additional capacity from those who work but don't consider themselves researchers, and making those people more sort of attuned to the need to question why certain things don't work. That's one way to do that. I mean, there are many, many aspects to this, but they don't have time. So I think that's an angle where when we talk of research capacity, perhaps we should think of anyone who can conduct research that helps sort of address the needs of this population. Because if we wait for researchers to do that, we may not have them there. They may not even be safe to go there. It will never happen, or they will only go once things have improved. So that's kind of late. So that's one angle to add. But I'm sure there are many other aspects, including community engagement, etc., which we have lessons, what we learned from malaria, etc. So this can be easily tapped into and used more. So I'll stop here.
Yeah, thank you. I mean, again, a common theme is perhaps just entirely disrupting or reimagining, the current methodologies and frameworks, the lenses that we bring to health research, not fit for purpose for this sorts of questions and action and progress that we're trying to achieve in this space. So very exciting, lots for us to take from this session. I want to pose the final question to Miriam, and then we'll hand over to Kabir to try to sum up for us today and inspire us to keep working together going forward. Miriam, one thing that we've talked about a lot in this session, and it's certainly played prominently in the Migration and Health Commission that was published in the Lancet, is really the lack of commitment and priority that funders, particularly major funders in health, are giving to migration and health. This is an age-old concern, the roots of which I need to put to you. Where is that coming from? Do you see this changing? And what's happening now that we're in this COVID era? Is this going to make us more difficult as migration and health advocates and researchers to acquire the funding that we need, or are some opportunities opening up that you see? If you wouldn't mind just finishing off on that note.
Thank you so much, Jocelyn. I think a whole other session on that could also be had, but I'll try to make it brief. I think that we have seen, both myself and obviously colleagues who've been working for many decades, including those on this panel in migration and health, we do see huge challenges in not only securing funding for migration health research, but also securing sustainable funding, especially as been mentioned by all of the panelists, which is, has leadership and ownership by LMIC institutions and researchers. So I think that still is a huge challenge and needs to change. One thing that we certainly found through the commission work and through work afterwards is that migration health tends to be, not only in research, but also in policy, sidelined. It often is an add-on rather than being a core component within a funding call or within a particular resolution or policy. And I think that needs to change, and perhaps COVID-19 is an opportunity for that to change in some ways. But I also think COVID presents unique challenges in that we had quite a lot of focus in 2019 on migration and health, and quite a lot of developments, particularly within the policy sphere, but which also related to research. For example, the resolutions, the Global Compact for Migration and Global Compact on Refugees. But some of that momentum has now been lost, unfortunately. And I think the same has been seen this year with a diversion of attention away from sustainable development goals, away from universal health coverage, and into sort of short-term emergency response to COVID. One of the risks with migration health research is that, traditionally, unfortunately, there has been a focus on infectious diseases and migration on sort of a biosecurity lens with regards to migration health research and migration policy response. And I think the risk really is with COVID that could reframe migration within that biosecurity lens rather than in a broader public health and right to health lens. So I think there's an opportunity, but there's also a threat to migration and health. So I think it is probably our responsibility as researchers and those working in multilateral organizations to make sure that we continue to have those strong messages that we have had and have increasingly had prominence for in the last years around migration health as being key to public health for all marginalized populations, including migrants, needing to be included not only in research but also within health system response. And I think we've seen that very clearly in COVID-19, particularly with the fact that we have seen migrants in many contexts, particularly those most marginalized, being excluded from health system response or from vaccination campaigns rather than being included, which is of course ineffective in terms of a public health response. But also more broadly, that is not a response of solidarity. So I think both a threat and an opportunity at the same time.
Thank you, Miriam. Thank you for finishing off on that, possibly positive note. And I want to thank all our panelists for engaging in this discussion. As I said, these are the sorts of topics that we could probably have, an entire conference on. And I appreciate so much that you gave your time to the beginnings of that conversation in today's session and to the organizers for allowing us this space. And I'm glad that everyone had an opportunity to expand upon some of their presentations, which were so, were so very valuable to this topic. I'll bring this to a close, and I'm going to hand back to Kabir, and he's just going to say a few concluding remarks. But on behalf of the Lancet and myself and the rest of the team and our colleagues at Lancet Migration, really looking forward to continuing to support you, amplify your work, and in whatever way that we can help you advance this global agenda on migration and health research capacity. We absolutely unquestioning in our commitment. So thank you all.
Thank you, Jocelyn. So I think I have the slightly enviable task of wrapping up. So I'm going to cop out. I'm not going to wrap up. I'll say some things which I think would help take us forward rather than trying to encompass everything. It's also the end of the day for many of us, so we're keeping our energies going. So I think 3 or 4 things that come out. One is, I think we've established that research on migration requires a sort of capacity strengthening that has to be institutional and not individualized. It can't be just a few interested groups. It has to be institutionalized within low and middle income countries. The priorities of policymakers, but also of migrant communities, need to be taken into account. And also, while there are some themes that resonate across the board, there are also many that are much more localized and context specific. So the research agenda needs to be much more contextualized. The role of health systems is key in generating and using evidence to address issues of migration and health, but we need to look beyond health systems as being political jurisdictions. We need to look at them as being made up of people and mobility as a basic activity of those people. So we need to rethink how we envision the boundaries of health systems. We also need to think about vulnerability and the fact that migration is, yes, it is a basic human activity, but it often creates massive vulnerability. And that really ties into and should really tie into our understanding of universality, universal health coverage, and leaving no one behind. And we need to think about those needs explicitly and not just as a migrants' needs explicitly and not just as a generic framework of people who are vulnerable, because their needs are unique. And of course, migrants we know are especially vulnerable to neglected disease or poverty and also to difficulties in accessing sexual and reproductive health services. We've not really touched on gender disparities in this panel, and I think that's possibly an omission. We should have done that. I think we had, there's a lot to talk about there, and the fact that women are disproportionately affected often, but also that men have unique vulnerabilities when it comes to conflict-affected migration, as do women. So gender is an important issue there. Migration research is clearly a complex area which requires interdisciplinary inquiry. I think we are all agreed on that there needs to be specialized needs, specialized capacities when it comes to addressing migration research, where human mobility is overlaid onto other concerns that vulnerable and poor people have. So with that, I hope that, with those 5 or 6 points, and we can build on those and continue the conversation and find a way to continue that conversation. I think there was massive commonality among all of us who gathered today in terms of the shared commitment we have to building research capacity in low and middle income countries. I think I can speak for my colleagues at TDR, HRP, and the Alliance, and at WHO as well. I know I see some of my colleagues from WHO, Ahmed Mandil from EMRO, And I'm sure that he would agree with me that this is a commitment we have at WHO, and we will strive. But ultimately, if we are really to institutionalize research capacity, governments have to get involved in funding the relevant research capacities. So that is the advocacy effort that is actually more challenging and more important that we also need to make. So finally, with huge thanks to Lancet, the Lancet Migration, Jocelyn, Miriam, both of you, to Fuad, to Juan, and to my colleagues at TDR and HRP, and to Joe for all your fantastic presentations, and to the audience for sitting through and bearing with us. I think we'll close this session and look forward to continuing and finding other ways of taking this agenda forward.
Thank you. Thank you all. Bye-bye.
Thank you very much.
Thank you. Thanks a lot.
Thank you.
Thanks, everyone.
Bye.
Thank
Bye,
you.
Joe.
Bye-bye.
Bye.